Hello, my name is Dominic Cushnan, and I have the privilege of working in the NHS AI Lab, heading up some of the work around AI and medical imaging, and we're going to be talking about that for the next 45 minutes or so. Today, you will have heard about the various work we're doing in the lab to enable the safe development and deployment of AI in our health and social care. That will be through the NHS AI Award, the work with the regulatory bodies, and the buyer's guide that my colleague Nina just discussed. And after this session, if you hang around, you'll be able to listen to my colleague Brummy, who's the head of AI research and ethics, and some of the work that she's doing. I'm going to spend the next few moments to give you a flavor of the work that we have done during the COVID pandemic, and specifically looking at the COVID chest imaging database. And then I'm going to introduce some of the most amazing people I personally have had the opportunity to work with over the last couple of months, and also look at some of the work that we're looking to do through the NHS AI Lab and the work around imaging. There will be time for Q&A. If you do have questions, feel free to put them into the chat as we're talking, and we'll attempt to pick them up as we go along. This is the first of many conversations that we'd like to have with you, so please bear with us, and we'll try to get back to you all individually. So at the start of the year, if you can remember as far back as then, we faced the biggest challenge that many of us have ever had. The pandemic has impacted all of our lives. Intrinsic to this is chest imaging, as the disease impacts the lungs. The only way to support this was through a national COVID chest imaging database. This has currently never been done before, and over the previous 3 to 4 months, the team and I have brought together all partners to build a national imaging database and the ability to then collect and link data sets. This morning, you will have heard from the Secretary of State for Health and Social Care, Matt Hancock, and he addressed 3 key areas. 1, we need to improve the access of high quality data for improving lives. 2, support research objectives. And number 3, which we'll talk about now, is making sure that we have better integration with the national health system and supporting innovators and entrepreneurs who can spot opportunities to improve and save lives. So before I introduce the panel, let me discuss with you what NCCID is. Now you'll have to bear with me, it's a long acronym, and we were not as creative on the acronym, but bear with us. It basically stands for the National COVID Chest Imaging Database, and it is a centralized UK database containing X-ray, CT, and MRI images from hospitals and patients across the country. It started out as an initiative, a joint initiative with NHSX and colleagues we've got today on the session from the British Society of Thoracic Imaging, BSTI, the Royal Surrey NHS FoundationTrust, and the AI Lab Strategic Partner Faculty. All of whom I want to say thank you to for working tirelessly over the last number of months to do work that would normally take 3 to 4 times as long. I would also like to take this time to give thanks to the many others who've been involved in this project through the Royal Colleges, HDR UK, research nurses, and radiology departments up and down the country. There's also been excellent collaboration with UKRI initiatives, the Centres of Excellence, and I personally want to say thanks to Emily Jefferson and Claire Bloomfield, who've been instrumental in enabling some of this work. At the start of the pandemic, what we saw was fragmented data sets of COVID chest images, and researchers and companies were starting to use these. These companies and researchers who've been working on medical images for quite a long time to determine the type, severity, and progression of any specific disease decided that they were going to pivot some of their activities to come and help us. But what they were struggling with was being able to access quality data sets that were representative of the UK population. This is where we have built out the National COVID Chest Imaging Database. And I would like to offer the opportunity for those of you who are not already working with us, if you're working in an organization, in an NHS trust, please do connect with us. Our contact details are on the NHSX website, where you can work with us to share your data with us. But also, if you are an innovator and you want to apply for access, we have a process where you can come and work with us on this as well. We also have access on our GitHub if you're interested in some of the code that we're using. I think it's quite important to say that over the last 3 months, we've collected data from 18 NHS trusts, which is representative of about 84 individual organizations, over 32,000 images, and I think quite excitingly, over 8 approved data users with access to this training data. We also have ongoing work with linkages to programs of work like ISARIC, and we also have been given the green light to work with the Scottish PAC system as well, and colleagues across NHS England and Improvement. I'm going to leave it to Mark and Joe to talk a little bit more about the work that we're doing and how we do this, and the work of onboarding organizations on a regular basis. But also, I think what this has really reinforced, specifically for me and the rest of the team, that it's really important for us to work collaboratively and at scale. It means that we can get things done quicker And we also have an amazing feedback loop to make sure that we've got the right processes in place. As part of the lab's mission, we're going to spend the next couple of months, as Indra mentioned in one of her sessions this morning, that we're going to spend some time looking at the discovery of how can we support the imaging community and expand on the existing work we've done during COVID. How can we help the innovation journey from the idea concept right through to the ultimate deployment? Working with our partners and colleagues across the board to address some of these big issues that have been discussed throughout the multiple sessions, including things like contracting and the value of data. So I welcome you to be involved in these conversations. This is an ongoing conversation. Many of you have been having them for many, many years. And we want you to come and join us on this journey. And the contact details of how to do that will be on our NHSX website as well. And that's part of the ongoing building of a community so that we're constantly listening to you. As we all know, we need to have good, qualitative, representative data. And we also need to be able to provide secure, safe, accessible access to that data. And these are the type of things that we want to build out. We also need to make sure that we have the ability to validate independently whether an algorithm does what it says on the tin. And that's what we've built this database for. We're keeping a high percentage of the database back so that we can test these models independently. We also want to make sure that we address the holy grail of innovation, which is how do we get these models back into the clinical setting and out of the academic work so that it's helpful and supportive to the clinicians and we're solving the problems that they need to be addressed today. I have nothing else to add at this point other than this is a start of a conversation. I have the privilege of working alongside these colleagues and I'm sure you'll have many questions for them. I'm going to introduce the panel now, which is Dr. Joseph Jacob, who's Clinical Research Career Development Fellow of the Wellcome Trust at UCL. He's also an Honorary Consultant Radiologist at UCLH. He's the Research Lead at the British Society of Thoracic Imaging and also our Clinical Lead within NCCID. Mark Hallings-Brown, Head of Scientific Computing, Royal Surrey County NHS FoundationTrust, and he's also a visiting professor for the Centre for Vision, Speech and Signal Processing, University of Surrey. I also one of my people I really like working with is Professor Erica Denton, who's done quite a lot of work for the healthcare system over the last number of decades, specifically looking at medical imaging. She's the Medical Director and Honorary Professor of Radiology at Radiology Norfolk and Norwich University Hospital, and she's also our current National Advisor for Imaging, NHS Improvement in NHS England. I'm looking forward to hearing what Erica's got to say about where we can add value. And then last but definitely not least, Rizwan Malik, who is the Divisional Medical Director for Diagnostics at Bolton NHS FoundationTrust, who I would like to have a conversation about how he implemented an AI technology during the pandemic. So without further ado, I want to open up a conversation to the panel. And in the first instance, maybe have a little bit of a conversation about what are some of the lessons and how we went about setting up the COVID chest imaging database, specifically things around IG, data collection, infrastructure, and how we went about collecting data. Maybe that's to start off with Joe and Mark, if you want to come in, talk about that.
Thank you very much, Dom, and welcome everybody to this interesting session where we really try and tell you what we've been doing for the past 6 months in relation to the COVID pandemic. The scale of what we try to achieve is something I think the NHS has long planned, but never really been able to do across so many different hospital sites in the country. And it was only really enabled by the COPI notice, which was a notice that allowed confidential patient data to be collected for a public health reason, such as the pandemic. So the COPI notice allowed us to start setting up this database. And this is a research database. So we applied for Research Ethic Committee approval and HRA approval. And once that was granted, we were allowed to start contacting sites to collect this data. We had a data protection impact assessment that we kept in-house, which was really our form of identifying what processes we put in place to collect the data. And then with every site that we were interested in working with, we sent them a data sharing agreement, which they electronically signed and then sent back to us. The COPI notice didn't extend to Scotland. That has a separate regulatory framework. So for Scottish data, we've undergone the PBPB application process, which is a public benefit and privacy panel health and social care document. So that allows us to keep the data for 18 months within NCCID, whereas the COPI notice allows us to keep it for the duration of the COPI notice, which at present expires at the end of March 2021. There's a huge amount of work that's gone into creating this database. For the HRA, we had to give a very detailed protocol that stipulates exactly what we're doing with the data and how the data flows between sites. So that's really been faculty, NHSX and Mark, who've put a huge amount of work and effort into creating this database, which has allowed, as Dom has said, 80 hospitals to contribute data at the moment, with other sites such as the entirety of Scotland contributing in the next month or so. Sure. Yeah. Go on, Mark. Did you want to
move on to just giving some details about our data collection infrastructure we put in place? So in interest of time, I'll try and be quite rapid with this. I think it's worth starting off with the requirements, though, that we had at the time. It was quite a difficult time to start such a process back in March, which seems such a long time ago now. And quite a lot of the requirements were quite a tough ask. We needed to, given that it was a national ambition, we wanted to ensure we didn't have to install any technology at any of the hospitals we want to be collecting from. So we needed to use existing technologies. We wanted to make sure that everything we put in place was as available as possible to ensure that we don't exclude any contributions due to technical issues, and allowing us to ensure that the data set is as representative as possible. We needed to enable the collection of both images and clinical data, so that's two separate data collection pipelines. We needed to de-identify the data in a consistent manner, so we wanted to avoid de-identification at the host trust themselves, but instead centralize that. We needed to have pseudonyms inserted via the two different pipelines in such a way that we're able to link our images and data together, but also to allow the future linking of the data to other data sets, other national data sets. And we had to allow for the lack of consistent use of the NHS number in radiology, which is typical as well, which is something we had to overcome. We also had to allow the filtering of the data as it arrived to ensure we didn't receive anything we shouldn't be receiving. So filtering out radiology reports, screenshots, derived data that might contain sensitive information, and also filtering out body parts that we shouldn't have been receiving. This is a chest database, not a foot database, so we need to make sure we filter those out as well. And then finally, actually removing burnt-in data that may be present on lots of portable chest x-rays. That needed to be an automated process given the size of the team and the scale we were looking to operate and the speed at which we wanted to set it up. And then the final step was the transfer of the data from the collection processes up to the NHS England data warehouse, where it's then subsequently shared with the third parties themselves. So there's quite a long list of technical requirements that were a real challenge, I would say. So the solutions we put in place are relatively simple. So for the clinical data, we distribute a template to the host trusts that collect the data for us, and they submit that on a regular basis via a secure web portal hosted at Royal Surrey with site authentication and client-side de-identification. The images are collected, as I said, through existing technology. So we utilize the image exchange portal for that purposes. It was something we could get up and running instantly because all the hospitals already had it. Sites were familiar with its use. There was no setup, no firewall changes, all those sorts of issues were avoided. And an IEP provided by Sector were kind enough to allow the automated insertion of the NHS numbers from the transaction form into the images as they flowed through the network, which overcame the issue of the lack of NHS numbers being present to typical radiology departments. When they go through the IEP and arrive at the Royal Surrey dedicated IEP node, we deploy what we at Royal Surrey refer to as our smart box, which is basically a kind of configurable rule-based DICOM router, which knows how to de-identify images based on rules configured for that particular trial. So it filters out undesirable images and does the things I described above in the requirements. The pseudonymization was vital that we were able to link across our data sets and the different collection pipelines. So we utilized NHS number and CHI numbers were encoded using hashing and complex salts, which allow the same one-way pseudonym generation and linking between the sets. The transfer process from the Royal Surrey up to NHS England is another kind of set of pipelines that take place which run additional checks on the data and images, including a final visual inspection of all of the images that have not been automatically flagged. So for that, we had to develop very quickly a rapid visualization tool to allow us to inspect these images at speed. So as I mentioned, we were developing this at speed. So I guess maybe in retrospect, some of the decisions we made might be different. So I think one of those is the provision of more automation, because some trusts might struggle with the kind of overhead of submitting this data via IEP. And in other trials that Royal Surrey involved with, we have deployed our smart box in such a manner that it sits at the host trust themselves, extracts the data, and automatically de-identifies and pushes it up to a central location. So basically kind of encompassing the data flow I've just described, but all in one box at the trust. So that's something we are now offering out to trust to be able to make the collection process a lot smoother and speed that up at the trust. And as mentioned, we're linking with other initiatives. One of those key initiatives is being ISRIC. So at certain sites where ISRIC is involved, then we can, our links with ISRIC will reduce the burden of that site to have to collect any clinical data points by negating the need to collect those data points for the patients submitted in the ISRIC database. So yeah, it was a fast moving setup, but we learned a lot along the way, I think, and it was great to be involved with.
That's really helpful, Mark. And I think that's a really nice segue to say, you know, if you are working in a trust and you're a radiologist and your organization is not on the list of organizations we're working with, please do connect with us. And we'd like to find a mechanism that's helpful for you, ideally with zero burden, ideally automated, so that we can work and collaborate together. So you talked a little bit about the linkages. Is there anything else that's worth talking about in terms of the clinical data sets and the value on that? I think there's a comment on, are these images annotated by clinicians? Maybe we can come to some of those kind of more technical pieces that would be helpful.
So one thing I can say is that when we set up this database, it was in the middle of the pandemic, using the knowledge we had at the time, which was that COVID was a lung disease. And as things have progressed, we've realized that it's actually a multi-system disease. And there are certain aspects of clinical data that we didn't collect in the beginning that we realized are becoming more and more important, such as patient's ethnicity. So one thing I'm really proud of is that a lot of this database collection was facilitated by radiologists, chest radiologists across the UK through the medium of the British Society of Thoracic Imaging. So it's something that the chest radiologists have really contributed to strongly. But at the time of the pandemic, resources were really at a minimum. So the clinical data sets we identified as being important had to be pragmatic and limited. And that's why now we're linking, to avoid reduplication, to larger databases which were pandemic specific, such as ISRIC. Also realizing that ethnicity is such an important factor in COVID outcomes, we've linked to the NHS segmentation data, which allows us to pull in ethnicity data for all the patients that we've collected data for. And now we're having further conversations with other groups, such as HDR UK, to see how we can best characterize the patients for whom we've collected a very bespoke, comprehensive imaging data set, but linked to omics, electronic health records, to maximize the information we can get. In relation to the specific question, are these images annotated by clinicians? We've got a field in our clinical data that asks for the disease severity measure on each chest X-ray and asks for the chest X-rays to be scored according to the British Society of Thoracic Imaging guidelines for COVID chest X-ray reporting. So those two fields are there, but the images physically aren't annotated. There was just no time during the pandemic for that kind of resource to be put to this, unfortunately.
Thank you so much, Joseph and Mark. I think that's a really good highlight to the work that we're doing. And I think it really plays to the strengths of making stuff happen quite quickly. And I think, you know, we have an opportunity over the next couple of months to think about this in long-term pieces about imaging and the types of data that we're collecting that's useful for building algorithms as well. It ties quite nicely into the next bit. I would like to kind of open up a conversation on really around the COVID chest imaging database and the processes for companies to get access to that data, but also have a look at what we mean by validation and why that's very important. So I'd just like to open that up for a discussion point as well.
So I'll say that one of the key aspects that we've tried to ensure is that the data used for training is separate to the data used for validation. So right from the outset, we've kept data separate. And we've tried to ensure that data that's being put into the validation data set isn't being used in other instances for validation by companies themselves. I think having the other aspect we haven't mentioned is we're also collecting data on patients who didn't have COVID, so who are repeatedly swab negative. So we have a control population that the AI algorithms can train against compared to the COVID positive patients. And the last thing to say is, if you see abnormalities on a chest X-ray or a CT in a patient with COVID, you may not know how much damage pre-existed on that patient's lungs from other diseases, from smoking, other factors such as that. So we've also ensured that for any COVID positive patient, we've collected 3 years worth of old historic chest imaging, just so we know what their initial baseline lung disease status was. And then we can identify how much of the longitudinal or long-standing disease sometime after COVID has disappeared is related to COVID itself, as opposed to pre-existing conditions.
So what I'd say, Dom, was that this your question segues into something you said at the outset. From my experience, what I found was that when the pandemic struck, we had a few things that all happened very rapidly around the same time. NHSX, was building up this national imaging database, as Joe and Mark very nicely outlined to us. The BSTI mobilized, and from the point of view of a chest radiologist or chest interested radiologist, it was incredibly helpful. The kind of work that Sam and Arjun put out, really giving us all these teaching points and collating that for us to tap into, to give the country a way of analyzing this. So putting those together was one aspect, but the third bit was anyone in the country who had any sort of AI interest was basically being bombarded. Let's be kind, and I think in most cases it was absolutely just with a desire to want to help in some way, shape or form. But I remember distinctly that there was one particular week where I think I had something like 46 messages of some shape or form, and they all took a really similar example. We've designed this, we want to give it to you, will you deploy atUCL? Some of it was, as I said, that because they genuinely thought it would be helpful. In other ways, it was effectively a disguised, we want your data, can we have it, please? And I think the point to make here is that if you weren't inclined to have some grounding in looking at AI companies and AI tech, some of the presentations were really very slick. Some of the ideas are actually very cool as well. But when you scratch very quickly beneath the surface, you find that they'd been trained on what, 10, 20, 50, 100 chest x-rays, and that isn't the kind of thing which you at all could deploy in a live environment for patient care. And so in that case, it was very nice to be able to, again, redirect these companies towards this developing database. So what we've got is the other aspects, I think, in the UK, and I think something which the NHS is getting better at, but hasn't been so far, is this view that if it hasn't happened on these shores, it either doesn't exist or it must be rubbish, otherwise we'd have known about it, right? And so we've got, on the one hand, some very niche small companies who just don't have the resources to tap into imaging to develop what are very, very cool ideas. And at the other end, we've got some internationally deployed mature products who want to come to this country, and yet the questions we get asked is, well, where else in the UK have we deployed it? How do we know it's relevant to what we want to do? And I think from the validation point of view, that's an entirely reasonable question to get some assurance on localization. And arranging some commercials from both ends, I think, will give us a little bit more confidence to be able to help increase the uptake of artificial intelligence solutions in this country, because I think those 2 points were a hindrance. So I'll pause there from this point of view.
I think that's brilliant. Thanks very much, Rizwan. I echo what you say. At the start of this, there was a volume, a tsunami of companies and people who were promising the panacea to all our problems. And I think, anybody that's played with any types of data sets knows that there's a process. We do have a robust process in this country about how we make sure that things are safe for deployment. And that's what we're here for. And it ties quite nicely into why we would go about validating independently algorithms. I don't know if anybody else wants to come in at this point. Maybe Erica, maybe you want to come in at this point.
So I think this has proved that we can do this. We can do it at pace and in a responsive, agile way, and that a national infrastructure is a hugely helpful thing when it comes to looking at databases of any type, but particularly in radiology and imaging databases. It's been a huge pleasure to work with the team and to see how this has evolved. And I think our experiences over COVID have catalysed us into being in a very different place in terms of our use of the AI lab and our engagement with the whole wider imaging community and artificial intelligence scientists and all of those geeky people who spend their time looking at data sets and trying to get things to do things differently. It's been music to my ears because I was responsible for the original National PACS programme, when we couldn't create an ability to access data sets across the system, and it always felt as if that had been a mistake, to be honest. At the time, the technology wasn't really there. We've now proved we can. And I think this has formed the building blocks for us to do things in a better way now. We can now coordinate guidance for governance, guidance on implementation and procurement of AI technology. And the way that we can do that from this experience has been accelerated because of the pandemic. And it is one of the good things that's come out of this time. I think as we move forward, the important thing is that we provide for radiologists, radiology departments, those who are interested as scientists, a platform and a suite of tools that will enable them to assess whether something is good and how we can then put something into an implementation process. The challenge for all of us is, as you've already heard, we get bombarded. I must get dozens of emails a week asking me if I could have a look at an individual artificial intelligence thing that would help me with a bit of my CT work list or a bit of chest x-rays, etc. And we now need to build on the experience we've had with this data set and put it to really good use. And I think that's what we're doing. And I think having this embedded with a national infrastructure is going to be vital for that. And I thank you, Dom, for you and your team for your work on this. I think it's really important.
Thank you, Erica. That's a lovely endorsement. And I think, you know, this is an ongoing feedback learning loop. And there's a comment here about, you know, the clinicians and innovators that are on this session. How can they come and help us? I think there are two bits on this. One, come and help, you know, have a look at the data, go and get data access to it. Come and join our community. Today, you'll have heard the announcement that we have got some platforms called the Future NHS website where you can come and collaborate with us. This is an ongoing conversation. We want to spend the next 3 to 4 months spending more time in the discovery of what this would look like and how do we as the AI lab add value. At the start of this, I announced that, you know, data is the key piece to this, but then you talk about the adoption piece. And I know, Rizwan, we've had many conversations about this. Like, it's not, you know, getting the tech that this is safe to use is one thing, but then ultimately deploying it into a clinical setting that makes sense is also ultimately the hardest bit to do. And I think at an industrial scale as well is the other challenge. How do we do this at scale that's useful, and goes into things like localization and you know, making sure that it works in a local trust. Does anybody want to come in on any other comments on that?
If I may, and actually it probably also answer in part the last question about the potential to collaborate with other initiatives overseas. I just wanted to make one point. So we're a district general hospital, and I say that with some pride. We're not a global digital exemplar. We're not a lofty London teaching hospital. And that's important. Why? Because we had a lot of engagement with NHSX, and we had a lot of discussion, learning from our point of view, and also taking advice to be able to grow what we did. So we didn't set out in principle to deploy what we did for the sake of doing AI, but what we had was, because we were being bombarded to have a look at these things, it just allowed us to think about, if we were, what would be a safe way to do it? What would be the problem that we wanted to solve? And I think that's the crux of it. So we've collaborated with an Indian company, Cure, as it happens. But the reason we touched them with a barge pole was because they were using a solution that they'd spun up and deployed in Italy. So again, it felt more safe and more confident because it was a European Caucasian setting rather than TB out in the far-flung parts of the world. But now having the fact that even using them in a hospital setting, we can point them towards the national database and say, do you know what? Get rid of the final bits of any questions and go and validate from that point of view. And I think that's just it. This database will give opportunity, because the NHS has really been seen in the UK as a slippery sphere to try and get any traction from. It's been really hard to get engagement. And this will allow a platform to some of the best from around the world to be able to help us, because ultimately the aim is to be able to put the best solutions that are available for the good of patient care in the country. And that's the aim that we're all after.
Thank you.
If I could address the last question that's just been asked. The question was saying it's great to see an independent test sets partition and that we're looking at longitudinal data. The way we're trying to answer the evolution of COVID in patients over time is by ensuring that the same mechanisms that have been used in NCCID are being used in the national COVID follow-up study. The FOSS COVID study, being led out of Leicester, is an £8.5 million UKRI study that's following up hospitalized patients following discharge with COVID to see what consequences they have for all sorts of health metrics, only one of which is lung disease. But we're making sure that the same pipelines for imaging data are collected from hospitals through Royal Surrey and then housed in NCME. And that imaging data can then be analysed, and we can track the patients by linking NCCID with FOSS COVID and ISRIC. We can track the same patients over time and theoretically see what their lungs look like before they had COVID, how their lungs were affected by COVID, and what effects COVID has had on their lungs going forward. So that is going to be incredibly valuable. And I think it's one of the things the NHS really excels at. In many other countries, you don't have this kind of system where the patient can be followed in their entirety.
Thank you. I'm conscious we've got 10 minutes left, and I think this was a really nice start of an ongoing conversation to open up to all you people who are doing innovation and are working at the front line of this pandemic. And this is the start of an ongoing conversation about how do we add value in the medical imaging space, not just on the diagnostic piece, but across it. Like, how do we add value into that clinical pathway to use algorithms that are safe? And I think, we want to keep that conversation alive with you. So please do connect with us, the Future NHS website, and you can contact us all directly. I think we're all amenable people to have conversations with. Imaging at NHSX. .nhs.uk is also our email address if you want to contact us as well. But in the last few minutes, if there's any other questions anyone wants to come and ask us, I want to open it up just to the panel really to add any other comments about evaluation, any other technical bits, lessons learned. How do you get the rest of the clinicians on board? How do we think about this going forward? And just really open up a generic question really. And if anybody's got any comments.
So I'd go back to some of how we did and what we did really, in that the important starting point was, if your first question is, how can I use AI? That's the wrong starting point. The first one should be, what is a problem that I want to solve? And then see if there are any tools that can do it. I know we're predominantly talking about the imaging database, but the other thing which I really want to talk, at least in passing about, is the buyer's guide to AI, because that was constructed really with these kind of experiences in mind, to ask the kind of, what we tried to do is share our learning, the kind of questions and concerns that we had, and consolidate them. And it was actually quite reassuring to find some comments in social media, which people who may perhaps have been rather nervous with, well, we don't want to set a precedent, we don't want to not ask the right questions, and just to give them a framework and to make this not the preserve of the geeky and the few, but to federate the uptake and usage of artificial intelligence within the NHS. And really, I guess, if it would be, what is the purpose of the AI lab in part? One of it is to be the trusted friend. Come with the questions that can assure you, and we would then have to put the structures in place to give that assurance.
Thank you. I think, the buyer's guide is absolutely part of that. And I think during the pandemic, we saw a lot of commissioners anxious about using algorithms, and rightly so. And I think that kind of addresses filtering out the types of, so if you're a company, you can obviously reverse engineer some of that buyer's guide, but we want to make sure that people are following the rules that are set in place for the safe use of AI. Did anybody else want to come in the last few moments at all, talking about past experience and how we do some of this work?
I might add one last thing, which is that we needed to be incredibly maneuverable during the course of the setup of this. If we were going forward and looking to create a national database for another disease, I think it'd be a lot more structured because we would know about that disease. One example that was a lesson learned for us was, in the beginning, when we collected the data, we thought this was not a disease that really affected children. And so we did not collect any data on children under the age of 11. For example, there was one patient in the whole of the UK who was 5 years old who was known to have died of COVID. And had that patient appeared in our database, they would have been identifiable. So we took the decision to not include any patient data for patients under the age of 11, so no one was identifiable. But of course, this thing evolved so quickly, and very soon children were being affected and being hospitalized around the country. And pediatricians from around the country wrote to us and said, please, can you start including children in your database? So we've got lots of checks and stops in the database before any data goes out to make sure that everything's safe and secure and non-identifiable. But this was a big lesson that we learned during the course of the pandemic that meant we had to pivot completely, which was not a small thing to do, but just speaks to the flexibility of the team that worked on this.
Thank you. Yes, you're bringing back memories to me. That feels like it was a lifetime ago. But yes, and I think that's one of the key things we want to do is make sure that we're collaborative and listening to the things that people need. I know, Mark, you've been working diligently getting that database up and running as well. So thank you so much. Does anybody else want this? We've got about 5 minutes, and I kind of want to open it up to, is any other comments or lessons learned that you think is worth us as NHSX and the AI Lab considering? We've talked a lot about the data pipelines, how we think about, I think we haven't explicitly said it, but how do we develop out the right training research environments so that we can give access safely, so that we can audit the use of the data and where it's being used? How do we make sure that those data sets are kept back for independent validation? And then ultimately, how do we think about deploying back into the viewer, really, so that Rizwan and others can ultimately use your technologies appropriately?
I'd quite like to add a quick comment about the validation data set that NCCID very cleverly thought at the very start to put aside, and that was a really great decision, which was formed on lots of the group's experience on previous about the validation of AI tools from other disciplines. And so having a very large independent validation set, which is completely unseen, is something that we started from the very start to build up. And we have basically almost 50% of our data goes into the validation data set, which is a very large number. The reason it's so large is that because we can't predict exactly the intended stated uses of these algorithms, we need to ensure that we can sample from this validation data set. So it's not just a single data set for one purpose, it's a large enough data set that we can sample and ensure we have fully representative data sets for the various different intended uses. So making sure we know the ethnicity, equipments, models, techniques, protocols, and we can allow for the variability of those across the country. Hence the national nature of this being very important. But it's also important that the validation set is large enough that we can power sub-analysis as well. So we have enriched data sets which can be used to look at secondary objectives in the validation exercises. And that's quite a challenge in itself, because it really means the data needs to be massive, really, really very large. And so that's something we're continually working on, is trying to expand the number of sites we're collecting from, not only to supplement the training data set to enable development, but to ensure the validation set is large enough to be representative for all the various tasks.
I think that's a really important point there, because in many ways, one sort of take home that we've had is, I hate to say it, but finding and deploying the solution was almost the easy bit. The hardest bit was, well, what now then? We've deployed it empirically, anecdotally, we think it's great. The clinicians think it's great. How do you demonstrate that? How do you evaluate it? And that's again where having the dialogue with the central agencies and with NHSX AI Labs is incredibly useful. And certainly we've benefited from hand-holding and would, but from the commercial point of view as well, it's incredibly important to have that validation data set as well, not just to prove it goes in, but it, as Mark just said, does it meet the use case that you've purported to deploy it towards?
Thank you. I have nothing else to add on this. If anybody else has got anything else to say at this point. Anybody else like to wrap up in the last few seconds? Everybody's very shy. It's getting a group of people together to talk about imaging.
I'm never shy, Dom. Yes, it has to be said. I'd just like to say thank you. I think this has been a really good conversation. I don't know, because I forgot to ask. I'm hoping this is going to be available for people to view afterwards and enter into a dialogue with us. And I would add that I think everybody involved in this space is right up for being contacted, so that we can continue a really agile conversation and we can grow our experience and our capability. The NHS is uniquely placed to be a world leader in artificial intelligence in healthcare, and particularly in radiology, and we really need to motor to make us that. And we can get distracted with the day job quite often. This gives us the opportunity to do something that will make the day job better next year.
Thank you so much. Joe?
I'd just like to echo what Erica said earlier. You know, we learned so much from NCCID, but we've shown that we can collect this kind of data for diseases from a radiological point of view already. So I think that's what gets me really excited, because, okay, the COPI notice, and that was one of the questions, it did allow us to speed this up. But we can do this for other diseases. So that's kind of where I see this the NCCID really fitting into the annals of radiology going forward.
Thank you so much. And that brings us exactly to time. So look, thank you so much, panelists, for joining me on this session. I also want to thank everybody that has been involved in this journey and those who are going to come and join us on this. We have lots to learn together. We have no intention of duplicating effort. We want to collaborate with you at scale if possible. And I look forward to doing that with you.